Hello, everyone. Welcome those of you on the East Coast wrapping up your day, and welcome those of you on the West Coast now seeing light at the end of the tunnel. My name is Jason Cronwall, and I am the Senior Market Manager for Ambu's A-Scope family of single-use bronchoscopes. We appreciate you taking the time to view this first of a four-part live educational webinar series covering topics related to bronchoscopy during COVID-19. In this series, experts from various disciplines will share their real-world clinical experiences performing bronchoscopy during the pandemic, will provide perspectives on the latest society guidelines and statements, and offer suggestions regarding how to continue performing bronchoscopy while maintaining a safe working environment. Today's webinar is titled COVID-19 at New York, Real-Life Experiences, and will feature Dr. James Horowitz discussing his experiences performing bronchoscopy on COVID-19 patients at NYU as the novel coronavirus swept through New York City in the spring. This session will be moderated by Dr. Oren Friedman. At the end of their talk, we will open things up for questions. Feel free to pose questions during the Zoom with the Zoom Q&A function at any time during the webinar. Dr. Horowitz is currently the medical director of NYU's cardiac care unit. He is also an assistant professor at NYU Langone Medical Center. Dr. Horowitz graduated from the University of Pennsylvania School of Medicine, did his residency at New York Presby Weill Cornell Medical Center, and then critical care fellowship at NYU Langone Medical Center. Our moderator, Dr. Friedman, is currently the Associate Medical Director of the Cardiac Surgery Intensive Care Unit at Cedars-Sinai's Heart Institute in Los Angeles. Dr. Friedman graduated from Tufts University, did his internal medicine residency also at Tufts, and then pulmonary and critical care fellowship at New York Presbyterian, where the two met. Dr. Horowitz and Dr. Friedman, thank you very much for your time. If you don't mind, I'd like to turn the webinar over to you.
Hi, everybody, and really happy to be here talking about a topic that I know that Jim and I feel very, very passionate about. As I was getting ready for this webinar, I was thinking how I literally just did a bronchoscopy on a patient yesterday who was about a month after COVID, who had new fever, secretions, elevated white blood cell count, and there was a concern for ventilator-associated pneumonia. And I know that Jim knows how I feel about this, but I feel that, the importance of doing bronchoscopy on diagnosing ventilator-associated pneumonia cannot be overstated. I think it is such an important tool in the ICU. It's a particularly difficult diagnosis to make. And on rounds this morning, the intern made a funny comment. She said, well, yesterday a low-yield bronchoscopy was performed. And what she meant was because the gram stain was negative and the cultures were negative. And so that allowed me to be on my soapbox and actually illustrate how important even a negative bronchoscopy is, because it allows you to focus your attentions elsewhere and away from ventilator-associated pneumonia. Anyway, the bottom line is this is a very, very important tool, very important technology. I can't imagine working in an ICU without the ability to do bronchoscopy, but COVID-19 certainly made this very, very challenging. So, Jim, I know that the New York experience was that a whole lot of bronchoscopy was being done. So I was hoping you could tell us a little bit about your experience for starters.
Yeah. Again, thanks for having me. Our experience was kind of, I'd say, bimodal. Week one, week two of COVID, you have to remember this is back in March, right? So we don't know anything about anything. We don't know what's going to happen. We know a little bit about renal failure. We know there's going to be patients with myocarditis. We know people are going to be intubated for a long time. And in China, they're eating lots of proning. And that's about it. We'd heard some preliminary data that maybe ECMO patients weren't doing well, but we didn't really have a lot of other info. And we didn't know how dangerous it was to be in the rooms. We didn't know how many healthcare workers would get sick. I mean, honestly, I prepped my own team by saying that, my basic guess based on nothing is that, probably up to a third of us could catch it from working in the hospital. And we need to be prepared for that. But yet we need to go in and do our best for the patients. But I mean, what kind of happened was, and again, I should say up front, nothing that I'm saying is really data driven. And, everything that I say could be wrong by next year. But I'll just tell you a couple of core take homes that were important for me. And one was that step one was there was a lot of fear. There was a ton of fear. There was distrust. People didn't know if the information from the government, from the institution was real. And people were scared for themselves and their loved ones. And lots of people lived in hotels that the hospital paid for, for months, while they're to avoid, possibly getting their families sick. And every single person had to make that individual decision in an absolute void. So, this was hopefully our once in a lifetime event of almost like going to war. But so what happened was, for the most part, a lot of your kind of typical airway, day-to-day maintenance was sort of shelved in the interest of not ever breaking that circuit and creating super spreader events. So, I mean, I don't know I can't tell you the exact workflow of how this was decided, but a lot of the different treatments were cut down or avoided. Suctioning was decreased unless you had a true inline suction, and bronching basically disappeared. I mean, it 100% disappeared at the get-go. And, and I'll tell you, I've been on many webinars for different groups, and I'll tell you that I've been on with 5-6 different New York City hospitals, and we all have the exact same experience. So I can tell you it's pretty uniform. Of that, we never ran out of ventilators, but we did have to resort to less than perfect devices. People were using the government LTV ventilators, the long-term ventilators, the portable ones. People were using anesthesia machines, and each one has their own limitations, including the use of the HMEs, which, Oren, I know you have a lot of experience with. So what we found was that in the very beginning, these folks were having a ton of secretions, and with the lack of these procedures, they were clogging their tubes.
I would almost add, I'm gonna jump in right there, is that it was all but banned. Bronchoscopy was all but banned as a procedure out here in California. I mean, it was banned not only in the diagnosis of the disease, but it almost became banned in any other patient because of the possibility that they may have COVID. So even, if you came in with respiratory failure and infiltrates and tested negative for COVID, and then tested negative for COVID again, and then tested negative for COVID again, and somebody brings up, well, maybe this isn't COVID, maybe they need a bronchoscopy, you would still be looked at as not only putting yourself at risk, but maybe it was suggested that you were putting the staff at unnecessary risk by performing this procedure. And, as many people know, I know you know, but I also went to work in New York City during the height of the pandemic. And when I got to New York City, one of the first things I saw was one of my former colleagues doing a bronchoscopy, and the approach was very, very different. So it seemed to be a different attitude by that point, and that it might actually be safe. So I guess, tell me, how do you feel this can be done safely? Well, number one, do you feel it can be done safely? And what are you doing differently to make it safe?
Well, I'll tell you, I think for me personally, and this is, again, 100% my personal take on things, after a couple of weeks of being there in the beginning, I mean, we were opening and filling floors within, a day. And as was everyone else, in the city, converting ORs to ICU rooms and all these things. And patients were just coming in boluses of dozens. It wasn't like, a trickle like before. So things were moving fast. And it wasn't quite clear what the best thing to do was. And then I remember, for instance, on like week 2 or 3, the end of March, I had this feeling of like, I don't know how to cure COVID. I mean, obviously no one does. And there's a bunch of clinical trials where, we're changing what biomarkers we check, rapidly. Some people are getting high dose steroids. Some people are getting enrolled in trials for these things. Some people are getting remdesivir. Some people are getting full dose anticoagulation. Because we're starting to see VTE happening in these patients. And I just had this thought, and I said to myself, you know what I can do? I can do fundamentals. I can make sure that everybody has pooped, everybody is being diuresed, everybody's lines are being changed in a proper amount of time. And again, everybody, everybody's airway stuff is taken care of, basically doing good fundamentals. And what happened was, I take no credit for this. It was other folks in my group who basically said, you know what, we're seeing these people clog their tubes, and we wonder why they're requiring these mega doses of sedation. And I wonder if maybe it's because they have so much secretions that they can't handle, their tubes are obstructed, they can't breathe. And they said, you know what, we just need to bronch them and do fundamentals. So they started doing that. We started doing that. We had at least 3 different bronch teams that were using basically almost exclusively disposable bronchs. One of the teams was using the traditional Olympus scopes, but the rest of us were using Ambu scopes, just because it was so easy to deploy them. And honestly, it's just a lot less to clean. I mean, if I'm going to bring the whole tower into this patient's room, there's no way I'm getting into all those nooks and crannies to clean it. But with the Ambu, I can just wipe down the screen itself, and I know that I'm not going to contaminate anything else. And what we found was just massive amounts of secretions. And that explained why people were self-extubating. I mean, there was one night where I did 4 reintubations in a night because of self-extubations. So we felt that, kind of more of these kind of toilet bronchs were very helpful for this patient population, as well as diagnosing, the subsequent resistant bugs that they got when they've been in house for 2 months and had been on steroids and all these things.
I want to ask you about that as somebody who is jealous of you in the sense that I actually come from an institution that does not have disposable bronchs, doesn't have the Ambu system. Look, as you pointed out, to get the tower in there, to clean down the tower, to get a large scope and that type of thing is a big ordeal, especially in somebody who's crashing and maybe having a mucus plug. So tell me, as someone who isn't as familiar with the system, what's it like setting that thing up? Like how quick can you get that going in an ICU room?
I mean, interestingly, we did the same thing with ultrasound. We basically moved away from the traditional large, expensive machines to point of care, small tablet-based devices. So for instance, we did the same thing with ultrasound using the handheld Philips Lumify, because I knew that echo machine has 5 million nooks and crannies. So basically to answer your question, the short answer is the tablet itself is a very small device. If you haven't seen it, it's, depending on which model you have, it's just a few inches across, and it has a battery powered, or you can plug it in. So you could literally roll in just with the screen in your hand and an Ambu scope and plug it in and do a bronch, or you could do what we have is we have it mounted to a very small airway cart with an arm that you can adjust to different heights and move around to get a better view. And we basically stock all of the other little attachments you would need to do your bronch right down there in the little airway cart itself. So basically you come in with only what you need, and then when you leave, you only have to clean, the tiny cart in the drawer that you actually open.
But look, as a pulmonologist, baseline pulmonary critical care doctor, I mean, I love my big, beautiful Olympus screen, when I'm doing something delicate, but I can tell you when I'm wearing my ICU hat and I'm running into the room, one of the most frustrating things is getting all the little pieces, the suction thing in, the part that connects to the working channel of the bronchoscope. Sometimes it's missing completely. Sometimes I'm stuck in a room and I realize it's something that's outside the room, which becomes even more problematic for COVID. So I'm guessing this thing comes completely put together, right? You just pop it in, turn on the screen, it's ready to go, or? You
really never even used one?
Honestly, I picked up one at a conference, and I have not used one like actually clinically. So,
again, I'll reiterate, we did the same kind of workflow with bronchoscopy, with ultrasound, actually with cardiac arrest. We stopped, and with intubation, we stopped basically cracking the full carts for everything because there were so many patients coming in so rapid fire that, if you went to go do an intubation, I mean, we started running low on airway boxes on week 2, not low, but low on some of the hyper-specific stuff that's in there for your kind of plan B, C, and D. And that's because we were bringing the whole box in the room, and then they were just dumping the entire thing in the garbage afterwards. So we had to move to a more a la carte approach, where basically, if you're going to go intubate somebody, you get a glide scope, you pick a tube, you get your stylet, and you get your cover, and that's it. And then your little RSI bag. And then you reserve your airway cart for a difficult airway where things go sideways. And then you knock on the glass and they throw the box in there. And I'm just saying that as an aside, because I think, the main reason that I thought it would be helpful to talk about this stuff would be to talk to people about all the nuts and bolts that, we learned so painfully back a few months ago. If this helps anybody in their institutions, I mean, that's essentially my goal.
Let's bring it back to COVID. I think a very granular question. So I'm curious what you're wearing in a room. One of these guys, shield, what are you wearing when you're bronching?
So we are wearing N95s. I mean, I wore the same duck bill that you have there. That was one that I was fit tested for. And so basically, you had your duck bill, and you had your gown and gloves and a face shield, and then we reused the N95s. We donned and doffed. We had a protocol. We had buddies watch us in the beginning. I think that we were just insanely careful with that process. And, as I mentioned, despite doing hundreds of bronchs, I mean, no one on any of our bronch teams actually got sick. And
so I'm going to stop you there, because there are many people and many institutions that feel like it is only safe to do a bronchoscopy with a full PAPR.
Yeah.
That an N95 is shield, that is not enough protection. But did people get sick in New York? I mean, are people getting infected?
I mean, you hear a lot of stories about people getting sick. And just go scan the New York Times. I mean, you'll find that at Elmhurst, they had several people pass away on staff, but those weren't clinical staff. Mount Sinai had a nurse manager. This is all New York Times that I'm quoting here, not any HPI or any HIPAA information. And I think that the bigger risk was, in the very beginning when we didn't know as much. People aren't intubated. They're just coughing and hacking that stuff into the air. And still, even with staff, you never know if they got it at the hospital or if they got it at CF or CVS. I mean, a lot of the times I felt more at risk at CVS than when I was actually working. But as I said, for our people, for whatever that's worth, no one got sick, and we just used standard disposable N95s. Look, if you could create a system, and I'm sure there's some hospitals that have a huge stack of PAPRs, that'd be amazing. You definitely feel more comfortable physically because it's basically, I had one during week 1 before I shaved, and it's like basically being in a little air conditioning unit. It's very nice. But it's just that, hospitals only have a limited number.
Yeah, I mean, in full disclosure, I am in a hospital that basically decided internally that you could not do any airway procedure without wearing a PAPR. And in fact, if you decided to only wear an N95, that again, you'd be in trouble. I mean, you would actually be considered putting yourself at risk. But I think your experience is hugely important for everybody to hear, because not everyone has those things. So it certainly puts you at rest that, that's probably just as good. So I happen to agree with you 100% that I think airborne precautions are airborne precautions. I don't think a PAPR necessarily provides you with any more support than an N95 and a face shield. I think the biggest risk, I think a lot of people would probably agree, is when you're doffing your PPE. Yeah. That's the time where you're most likely to get infected. And it actually kind of concerns me when you're taking off your PAPR that it's actually a lot more labor and involved than taking off an N95 or a shield. So I actually kind of wonder that you actually may be placing yourself at a little bit of an increased risk. But, one thing I really wanted to get back to you about, and specifically the COVID population, was, with the New York experience and the secretions. But before I ask the question, I just want to remind everybody to post your questions and answers in the Q&A forum. So at the end, we can review them and go through everything. But I think New York, in a sense, had a very unique experience because there were so many LTV ventilators, so many transport ventilators that were being used that were supplied by FEMA that lacked the normal heat and moisture exchange of our usual Puritan Bennett, Servo, the fancy ventilators that we're used to in the ICU. People were plugging up all the time and were having acute, hypoxemic events where you had to run into the room and suction them out. So I think your experience with having to do all these sort of emergent bronchoscopies is a bit different than the rest of the country. I don't know if you have any further comments about that experience with all those secretions.
Yeah, it was, look, in the real world, as you know, there's a huge variation in, how much people bronch and what they believe in, is an indication for bronchoscopy. And I know where I stand and I know where you stand. But I'm just saying that in this scenario, it was a combination of the absolute volume of patients plus the, I think that the fear around doing those traditional clearance procedures and having HMEs on every event that in this just disease, that the amount of secretions was insane. And And we think that bronching was very important for most of those cases. And like I said,
I agree. I think that's one obviously huge point is the acute mucus plugging, and related to the experience in New York. But I would also say, I think all of us have shared the experience that these patients are intubated a very long period of time. In some studies, in a median length of time of intubation of 20 days. I certainly have people on my service right now that are 2 months into their COVID who are still intubated, that we can't even get to the point of tracheostomy because their FiO2 requirements are still so high. And those patients are just intubated so long that their tubes eventually clog off, their airways eventually get full of secretions. I'm curious, what are some of the other examples of why you might end up needing to bronch a COVID patient? And I'll ask you right up front, how about for intubation? Did you ever do bronchoscopic intubations on these patients?
I personally did not. I mean, we decided early on to try to standardize a lot of these things. We tried to standardize how we did intubations. We tried to standardize how we did cardiac arrest, again, to protect staff and to conserve disposables as much as possible. So we went basically the route of glide scope for everyone to keep the person intubating the furthest possible, from the patient's mouth, and to RSI all these folks just to minimize the secretions that get expectorated. And I mean, again, I should add that if I'm going to bronch this COVID patient, I'm going to paralyze them before I bronch to minimize secretions as well. I mean, that's my personal practice. And in this environment, I mean, some people there definitely were lots of different methods. Some people would clamp the tube as soon as they unhooked it from the vent, and then just do a quick pass and get as much as they could, while watching the SAT. I used the traditional, bronch adapter and just bronched as I normally do. And I sort of just covered, once I kind of punctured the seal of the bronch adapter and put the scope in, I would just kind of cover the whole thing with a piece of plastic. I don't know if it does anything. It made me feel, 5% better. But
do you pause? I'll ask you right there. Do you pause the ventilator when you're inserting the bronchoscope through the adapter?
I did not. Okay. But like I said, these are all great questions, and it's hard to know what the best method is at this point.
Do you insist that a patient be in a negative pressure room if you're going to do bronchoscopy? So
that's a great point. This is one area where we're an outlier, which is to say, our hospital the building itself is less than 2 years old. So we had the capability to make the entire floor negative pressure. Okay. So, we have an older building that has the traditional ICU with, 2 ICU beds, 2 negative pressure beds per wing. But then in the new building, we could literally flip a switch and have the entire floor be negative pressure. I'm told that technically it wasn't quite as negative as the traditional, 2 rooms, but it was, better than nothing. And so we did that. And then I certainly think you're very lucky there. I think, when I was in New York at one of your sister hospitals, they had converted some rooms that weren't previously negative pressure rooms into negative pressure rooms by adding a vent in the window. So that's certainly one solution. And then in my current hospital in Los Angeles, we just simply did not have that luxury. We had very limited negative pressure rooms. So if you were stuck doing a bronchoscopy without a negative pressure room, you kind of just had to at the beginning. Later on, they developed they brought in these large HEPA filters. So it became our practice that if you're going to do bronchoscopy, turn on one of these large HEPA filters within the room that we theoretically would give you a little bit less risk. Another question for you. Any experience putting like a drape over the patient, or a clear plastic drape, and bronching under that? That's exactly that's what I did. Not, that was my practice. That was definitely not a system-wide practice, but I did that just for small added level of possible safety. And again, I have no idea if that actually adds anything. Going back to what you said originally with the setup itself. So as I said, the reason that we like the disposable is that you basically bring the scope in. You bring the screen in, you bring the scope, you press the power button, the thing powers on in like 30 seconds. And then you literally, the end of the scope has an arrow that's like blue, and the side of the screen has an arrow. It's the same color. You just plug it in and then it turns on. You don't need any of the traditional adapters for the suction and the working channel like you have for the traditional Olympus tower. And so that makes it's just a lot less things to forget when you go in the room. And then all you need to have is just plug in your suction.
So one worry I always have, in bronching these patients is that that the BAL fluid, I just imagine it's teeming with virus. And that stuff is probably, like it's like dynamite, like infection, that I'm worried I'm going to kind of spill it on myself when I put the cap on or as I'm disconnecting it from the suction. So I'm very interested in the broncho sampler, I think that Ambu has, where it's sort of a built-in BAL container. Tell me a little bit about that.
So as I was saying, the concern is that when you use a traditional trap to do your lavage, you have to hook on that rubbery plastic, and then you have to pull super hard to pop it off, and you're clearly spraying stuff everywhere when you do so. So this thing basically is an adapter to the Ambu that basically loads the thing on for you, and then you can swap them out very easily, and it'll make more sense once I show the video. So basically, this is just me and my friend in my little sim lab. He's attaching the adapter, and then you hook on the plastic trap. It's super easy and super intuitive. And then when you want to suction when you want to do your lavage, you change the lever there, and when you want to suction to the wall, you switch it back up north. And then once you do one lavage, you can just snap on the second one right there. And then when you're ready to do your lavage, you flick the switch again. So it's super intuitive, and I did not have it during COVID, which is super annoying because it would have been great. And it just makes the whole thing a true one-person procedure. You don't need an RT to help you switch the traps out. You have lower risk of contaminating yourself and others, I believe. Again, no data, but I believe. And
that thing is pretty sweet. I want one of those now.
You don't run the risk
I'll be honest.
The trap flipping upside down and suctioning your specimen into a canister. That is not an issue with this. And I
hate that.
It's super convenient for definitely makes my life easier. And
honestly, in fellowship, we would hand syringe and hand pull back the BAL, unhook it, squirt it into the bottle. That was how we were taught. I still think there's advantages there, but I think from an infection control perspective, I think that's awful. So
I remember one of your fellows used to tape the thing down. Used to tape it to the bronch so it wouldn't flip over, which was messy also.
That's what I do in my current institution, which it does. It flips over, and then you still have to pop it off the bronchoscope when you want the sample, which I imagine is potentially spraying things when you do that. So
there is a question.
We're starting to run a little short on time. Any other reasons? I think it would be helpful to hear any other reasons that you would imagine you might need to do a bronchoscopy on these patients that we haven't mentioned. I should ask, diagnostically, have you had a patient where repeated nasal swabs are negative? You're doing a bronch to establish the diagnosis of COVID?
I have not. In the early days, the tests were less reliable, and you'd have patients who'd have literally 3 or 4 negative COVID tests, and then the 5th one coming positive. I would say that the bigger use was, a lot of folks were getting high-dose steroids in an attempt to tamp down that cytokine storm. And so what happens is then when they're, 20 days in, then they're developing, ventilator-associated pneumonias or fungal pneumonias or resistant pneumonias. And then the bronch can become very helpful again to diagnose those folks to guide your antibiotic therapy.
My own experience is I have been tempted to do that. I think early on I was up against a tide of a lot of colleagues that thought that was a dangerous reason to do a bronchoscopy, although now, as everyone's got a little bit more comfortable with the disease, we recently had, this wasn't me, but I was actually talking to a colleague this morning, had a patient tested negative multiple times, took to the bronchoscopy suite, were very careful. They used PAPRs. They did a BAL and a transbronchial biopsy. It turned out the patient had COVID. So, wow. I think, the viral load is probably higher in a lot of patients, deep in their respiratory culture. So it's hard for me to suggest that to everyone because I realize everyone's kind of concerned about the infection risk, but I think it's a cautionary tale to say that it's very possible. And I think the other situation that I alluded to, which gets me very much as a pulmonary critical care doc, is that you end up with people with respiratory failure who test negative, and there's a temptation to just treat everything as COVID. Give them remdesivir, give them steroids, and it's not all COVID. People are still entitled to have eosinophilic pneumonia, other viral pneumonias, negative pressure pulmonary edema, vaping-induced lung injury. And by the way, these are all cases that are coming out of, top of my head that I can think of, in whom everyone was tempted to think that they had COVID and were reluctant, I think, at times to want to do bronchoscopy. Anyway,
so that points to that's a great point in that, my experience in New York in March and April was different because everyone did have COVID. But as we deal with this pandemic for the next year, 2, 3 years, you're going to have to start having a differential diagnosis. Like you're going to see those other things that you saw, whereas in March and April in New York, everybody else just stayed home. And we're seeing the end effects of that now. I do want to address one question there are a couple of questions that came up already about Ambu, the scope itself. And I'll say that they're asking about how does Ambu scope image quality and suction compare to reusable scopes? And that is a great question and probably the most common question that I hear from people about scopes. And I'll tell you this, the reason that we started using them in my institution was when we have traditional scopes, we have a lot of them, but we were creating these emergency airway carts that were basically being used for difficult airways, and we're going to be standardized across the house, basically every ICU and the ED, so that if you had a disaster, you had X, Y, and Z in those drawers. You had your crite kit, you had a trach kit, and you had a bronchoscope available in all these places. And so I was super excited that my institution invested that money to do that, because I think it's a huge patient safety initiative to do that. And so I started using disposables more and more. And I found that basically I love the fact that I could set up in 5 seconds. I love the fact that I could stop using those annoying adapters, frankly. And I love the fact that I could easily save images. And then now with the newest Ambu screen, you can actually upload them directly to Epic or to your EMR. And I found that using iterations, I've used Ambu AView 2, 3, and 4. And while the suction certainly was not great in the beginning, Ambu 4 has fantastic suction. I don't know that going head to head with a traditional scope, I haven't done enough head-to-heads to say whether one or the other is or I can't say that the Olympus is dramatically better. It may be slightly better. That's what some people have said. But I tell you, Ambu is catching up, and I have definitely removed some very large things with an Ambu scope with and without biopsy forceps. And I think
there's a question about image quality, screen quality.
The image quality is very good. The current Ambu is not yet HD, but I'm told that next year's model will be HD. But the image is great.
Before I forget, I'd love to hear a little bit more about, so you guys have also had a really large tracheostomy experience. Tell me a little bit about that.
So again, this was at our institution, we found that there were kind of a couple different phenotypes of patients, and there were those that stay, as sort of Oren implied, that stay, they're on the vent for weeks, but they're still on, crazy FiO2 and PEEP, and you can't trach them. But there's also there's also a huge group that sort of is just stuck, at like 40 or 50% FiO2, and you just can't get them off the vent. And so my group moved, again, not taking any credit for it at all. It has nothing to do with me, but just the folks who I work with moved to kind of early tracheostomy for these folks, which is something we've been doing, in critical care in general anyways. And again, with that group, obviously those are all bedside perc trachs using a bronchoscope. And they did, I think, over 150 trachs at the bedside. And again, no one on the team got sick. And again, there's no PAPRs. This is just standard reusable N95s.
It's interesting you mentioned early tracheostomy, and I was just looking at a study that looked at duration of positive PCR, which can be extremely variable. People can test positive for weeks. I think the record was 83 days where someone continued to test positive, but no study has yet been able to find a live virus after 9 days, been able to grow it out of culture, which sort of suggests that there's a long window of time that people test positive, but probably the true infectious window is smaller. So when you say early trach, like how early are you guys talking? Like, what do you mean?
I mean,
Day 10?
Yeah, 7 to 10 days. Depends on the course, and it depends again, as we mentioned, like on how high their vent settings are.
So the somewhat related question is, one attendee is mentioning that there was a non-peer-reviewed study that came out of University of Florida showing that there was viable virus from air samples in the hospital rooms of COVID-infected patients. By the way, I haven't seen that study. I don't know if, Jim, you have a comment about that in terms of safety of bronchoscopy. And
Well, I think there's been a lot of data that the virus remains, aerosolized for up to 3 hours in the room after a super spreader event. So, obviously that's a huge issue. And again, like I said, we have negative pressure rooms. We were very, very careful with our PPE and donning and doffing. And I'll tell you that in the course of, the main burst in New York, I personally did intubations, bronchoscopy. I did several transesophageal echocardiographic echoes. And, these are all super spreader events. So we were cautious and careful, and we only did them when we thought it really would make a difference for the patient. And, we did okay.
My own take on that is, and I agree 100% with you about if you wear proper PPE, I think you're okay, is that there seems to be a definite divide in sort of that, I don't want to call it basic science research, but that virology research about how long you can culture viruses off of surfaces, and how much, how you can get viruses out of the air versus the clinical, experience on how people get sick. And there clearly seems to be a divide. It's sort of like, yes, maybe you can find virus on a surface at 2 to 3 days, but it does not really seem that clinically people are having a tremendous amount of fomite transition. It's not like people are not getting sick by touching a wall, 3 days after somebody passed by that wall, right? People are still mostly getting sick by face-to-face contact without masks, aerosol transmission and that type of thing, speaking, coughing, and sneezing. And so it seems that these are they're both true, but to me, it doesn't mean that that's typically how people are going to get sick in their room. And certainly your New York experience with that amount of aerosol generating procedures and not wearing even PAPRs, but just N95 and face shields and having basically nobody getting sick would suggest that there still is good safety there. Would you agree?
Yeah, like I said, there's no warranty on these comments. We need data, and the first stuff is still sort of trickling out now. But I can just tell you our experience, and it might be because we have a brand new hospital with, where we can make the whole floor negative pressure. But again, it's not the same true full negative pressure that you have in your 2 or 3 ICU negative pressure rooms. But to address one of the questions from the attendees, when do you decide to do, a bronch versus aggressive pulmonary toileting? And that's a great question. If you have, enough staff and enough RTs and nurses to do that, I think that's a great option as well. One of the things that we did, and I'm sorry for using the same caveat, but it was back in March and April, it was just so many hordes of patients coming all at once that, there was just so many patients who were intubated with so many secretions and so many requirements. But what we did one of the things that we did do was make our pulmonary toilet even more aggressive, which was to say, literally have a log and say every hour who suctioned the patient. And in order to conserve PPE, what we said was whoever goes in the room, meaning if the intern goes in the room, suction the patient with the inline suctioning. If the RT goes in the room, suction the patient. If the nurse goes in the room to do something else, suction the patient, and then log it. And that way you're not wasting PPE with frequent trips in and out. And it's essentially, it's a bit like the login sheet on the McDonald's bathroom, but it is what it is. There's a reason that works. So we started doing that. And I think that could help you avoid some bronchs as well. And if that's, safer for everybody, that's great.
I too have a thought on that, and I agree as well. But there's clearly limits. So I think with the inline suctioning, First of all, if you're going to go, blindly down with an inline suction, it's almost always going to end up on the right side. It kind of usually terminates in that sort of right middle lobe, right lower lobe area. So if you've got thick mucus plugging, atelectasis, or even pulmonary lung collapse on the left side, a whole lot harder to get that out with the inline suctioning. Other, situation with that inline is sometimes when it's really, really dense and caked in, you just can't get it out with inline suctioning. And I typically get the sense that that's happening, number one, by if there's actual radiographic findings. Number two is if you go into the room and you see that there's a lot of variability on the exhale curve, and you can sometimes tell that the patient's becoming very dysynchronous with the ventilator or trying to gasp for air. You go down with the inline suction, and I don't know if this is just after doing this for a number of years, but I get a pretty good gut instinct when I think I know that the problem is the fact that, yes, you're coming up dry with the inline, but I guarantee that there's something deep down in there.
Yeah,
you just know it.
Something just feels sort of funky. You're not getting anything up, and then you put a bronch in, you're like, the tube is like 90% obstructed.
Yes.
And something terrible is going to happen at 3 a.m. with that patient.
Right. And sometimes the RT and the nurse will say, but it's dry, it's dry, it's dry. I'm coming up a million times dry. I'm not getting anything. And you've seen it, right? You go down with the scope and it's full of stuff. So I think you got to go with your gut too on that as well. And I have, one other thought I might add as well is that I don't necessarily think that it's less risky to be suctioning in and out with an inline than it is to put a bronchoscope down and suction. Now, separating samples with a bronchoscope, that sort of thing, that's different. I suppose the only added risk, as I'm saying this out loud, is maybe when you're introducing the scope into the ET tube, but that's where I like to pause the ventilator. Yeah. Or, if I'm having to disconnect parts, I actually clamp the tube, pause the ventilator, reconnect things. And I think then that can be done actually relatively safely.
Yeah, exactly.
Other questions here. Let's see. Have you considered any lung recruitment techniques during a bronchoscopy? Thought on that, Jim?
I think that you take that one.
So I will think I take that to mean like maybe adding PEEP and doing that sort of a thing. And my answer to that is yes. I'm just a proponent in general of lung recruitment. So I will do that in two situations. One is I go down there with a bronchoscope, I'm suctioning out a bunch of stuff, and I see that the airways are narrowed, relatively collapsed. And especially if I'm doing a lot of suctioning where I know that I'm actually probably de-recruiting with my bronchoscopy, I will then often, after I'm done with the bronchoscopy or take a pause, crank up the PEEP. And, I'll often crank the PEEP even as high as 20, 25, hold it for about 2 to 5 minutes, then 18, 16, 14, maybe, and bring them all the way back down to where they were to begin with, 10, 12, whatever it might be. And I kind of look at the oxygenation. I see if that's actually improving. I look at the end-tidal CO2 waveform. But yeah, so I will add that in. The other situation where, I don't know if quite the word is recruitment, but I will increase the PEEP is if I get into an issue where I'm having some bleeding. Either I've caused it by my bronchoscope, rubbing up against very raw mucosa, or I just find bleeding. And, PEEP can actually work pretty well as sort of like a pneumatic stent to bleeding. So I will crank up the PEEP if I find that on bronchoscopy as well. All right, here's another one. Besides sharing suction duties with whoever goes in the room, what ideas have you come up to conserve? This is a good one. Conserve PPE. You mentioned you're wearing N95s instead of PAPRs. Have you had supply chain issues? Why don't you take those two?
Yeah, that's a great question. It's, again, I'm not sure how. I would be very interested to know how things are going right now in Texas and Florida with their supply chain, given that these other parts of the country had some time to stock things up. I will tell you that I definitely thought back to training, and when I would, you'd go into a rule out TB patient who was clearly not going to be TB, and you go with a whole team of 12 people and put on an N95 for 30 seconds and throw them all in the trash. I thought about that a lot because we ended up reusing our N95s. Every hospital in the city was a little bit different, but I'm pretty sure everybody was reusing for several days. We actually, were collecting the discarded ones to see if we could kind of clean them and recycle them, as all that stuff was coming out in real time with UV and temperature to reuse masks. But our protocol had been to reuse the masks. You would basically wear a surgical mask over your N95, and then you'd put your N95 into a brown paper bag. And then basically everyone carried around their brown paper bags every day. It'll be a long time before I see a brown paper bag and think of, a PB&J. It's going to be a couple of years before that gets reassociated for me. For me, it just means a COVID. But I'll tell you that my institution did what I consider an amazing job of getting us PPE. And I'll say that because the isolation gowns kept changing color. Like one day they were green and one day they were blue. And some people were like, well, are we running out? And I was like, no. That's just because the institution is literally going everywhere in the globe to get us PPE. They're just, right. I don't know what connections people have, but they just did an amazing job. And, I just worry about like the smaller independent hospitals that don't have, the resources to do that.
It's funny. I thought the same thing. We get these surgical masks, and almost by every week it comes from some other new company from around the globe. And it is pretty incredible how people have been able to find that. But and I would echo that same experience. We definitely reused our N95s. I mean, interestingly enough, I just read a recent article. It was actually really well done that looked at various different masks and reused masks. And it actually turns out that even multiply reused and even expired N95s actually still work really quite well. And that, those hospitals that have cleaned them using either peroxides or ethanol-based cleaning solutions, they still work. They actually still block aerosols. So that kind of put a little bit of fear to rest about reusing the N95s. We definitely reused our face shields. We definitely went from disposable gowns to now reusable gowns that are getting laundered because the disposable gowns, I guess, were harder to get. We went through multiple iterations of hand sanitizer to the point that the hospital began, interestingly, conserving all the Purell and using these spray bottles of an ethanol-based solution. So they basically used, I guess, ethanol, and we would spray that on our hands. And I actually grew to like those because you could spray them all over your feet, all over your scrubs. You could just cover yourself very easily if you felt like you just came out of a COVID room. So anyway, so that I think was pretty clever as well. Do we have another one here? I think we've gone through all of our questions. Maybe I'll have one last question, which is, I think, given that this is about, the Ambu scope and disposable bronchoscopes, and actually on that multiple bronchoscopy societies have seemed to suggest that that's probably a better option for patients who, with COVID, to try to use a disposable scope. And any last thoughts, Jim, on the advantage of using an Ambu scope in this situation?
I mean, like I said, in my transition from, first using them for one indication and then, using them more and more, I pretty much, my belief, again, is that eventually everyone will use disposable for everything. And the reason is that the technology will keep improving. There's multiple companies making these devices. Every iteration gets better and better. You don't have to basically think about how often you see someone with a $20,000 Olympus scope who doesn't pre-clean the scope, with that blue sanitizing fluid, and then just leaves a crust of proteinaceous gunk inside the working channel. And then you have a patient, bite it, and then the fiber optic cable gets bent, and then you have to repair that. And then you have to actually, find and pay a human to carry this thing downstairs to get cleaned. And then carry it back up to be restocked, and then you have to pay the technician to reprocess the scope itself. And I don't know if you've ever seen these machines. I've snuck in; they're massive. I can't imagine how expensive they are. I'm sure it's ungodly, and the regulatory burden around that must be insane also. And so that's why I just think more and more disposal will be the way to go. And also, if you look around, you'll see case reports here and there of people sampling supposedly clean scopes and finding these resistant bugs that are kind of stuck in little mini microabrasions after many reuses. So that's why anyone who asks me, I firmly believe that's the eventual future. And once you start using them in real life, it's just so much simpler, so much easier.
Those are, I have to say, very compelling points, and I think you're making a really excellent argument there. It makes a lot of sense to me, so I really appreciate that. I think the only thing I might add is that I think with the large screen, high def, fiber optic scopes, I think there's still a role there. I think they're just two very different technologies for different problems, right? So if the issue is acute left lung atelectasis and mucus plugging, in an ICU, perfect. If the issue is, I'm going to inspect endobronchial stent, in the bronchoscopy suite, maybe adjust it, okay, then use your scope and that type of thing. But you probably don't want to use that scope in the acute setting where the patient's going to bite on it and et cetera, and all those other problems you mentioned. So anyway, that's great, Jim.
But, I'm not going to be the one to adjust the endobronchial stent, but I can tell you that because I'm a nerd, I take my Ambu scope and I hook it up via a cable to the 70-inch HD TV in my patient room. And you can basically have the image be up there as well. And then with the newer screen, which I just got, it's actually just an HDMI cable. So if you want to have, a 50-inch screen that you can buy, on Amazon for $500, you can just take an HDMI cable and plug it in and then mirror your image right there, if you want to have that kind of big screen experience like you do with the traditional tower.
That's a cool idea. Very cool idea. All right, well, I'm all out of questions. I don't know if Jason, if you want to jump in and have any other last thoughts.
Well, I wanted to thank you and Dr. Horowitz for this fantastic discussion. It's been really very insightful. As mentioned at the beginning, this webinar is the first of a 4-part series, and we have 3 more webinars scheduled this month. So next week's webinar takes a look at the recent International Expert Panel Practice Statement on Bronchoscopy published in Respiration. The webinar in 2 weeks looks at the reducing the risk to patient and healthcare provider during bronchoscopy. And then the final webinar this month looks at the health economics of reusable versus single-use bronchoscope technology. So final comments, and that is thank you all online for taking the time to attend this webinar. It will be available for replay online next week. This concludes the webinar, and I wish everyone a pleasant evening. Good night.
Thanks, everybody, for participating.